So in the approach is more important. And then subsequently, which modality will you use first, and subsequently which modality has to be followed up, and what should be the differential diagnosis, and what is the most probable diagnosis. So these are the areas we will revolve around. So last time also we have used so how will we differentiate between the various lesions, and what is the effective and systemic way in which we can approach the lesions. Okay, so there has to be something. So what are the imaging modalities we are having? We have discussed that last time. So which is the most common imaging modality that has to be used? So intraoral radiograph, or OPGs, intraoral followed by OPG. So that is the main. So there are so many projections. So there is periapical view, so that will give the best visualization of the apex, the root, the root part. Wide viewing projections, that will give the crown part, and occlusal projections. So that will give the entire tooth plus the anatomy of the bone. So these are the three main projections that we are using into the intraoral radiography. Okay. So each and everyone have its own advantage and disadvantage. If you are only concerned about the crown of the teeth, then you use Bart's viewing projections. If you are concerned about the root of the teeth, then it is the periapical projections. If you are concerned about the surrounding anatomy of the bone as well, so whatever covered into that oral film, then you have to do occlusal projections. So these are the typical projections that are used in the intraoral radiography. Intraoral radiography will have very high resolution as compared to the CT and MR both. Like if any bone tumor, it has to be integrated in view of the intraoral radiography. You should not report these tumors without intraoral. If there is nothing is there, then we have to ask OPG, because we don't have any intraoral radiography. Practice, we can ask for radiology whenever there is a jaw tumor that is coming up. So sometimes we will ask it, just do a scan, just do an OPG. Then cone beam and computed tomographies that we have discussed. So what is the difference between intraoral radiography and panoramic radiography? Which is better at both times? Like advantages of OPG over intraoral radiography, and what is the disadvantage of OPG over intraoral radiography? So OPG, it will be a panoramic view. The only thing that it overlaps the structure. So there can be false projections. So, and there can be distortion of the image distortion is there, because it will move, the gunter will move, and then there is a film set is there, so they will move like this. So there will be multiple overlaps, because there can be false interpretations. So that's so intraoral radiography is preferred, but only thing the FOV is very less. You can only image 2 or 3 tooth structure, not beyond that. So these are the some of the areas. The same thing will apply for the cone beam versus computed tomography. Then, what is the role of magnetic resonance imaging?
In case of any doubt, like if there's a manifestation soft tissue component, can you MRI?
So whether it is arising from the bone or it is arising from the soft tissue, whether it is cystic, whether it is solid. So if it is cystic, whether there is any enhancement in the peripheral area. So all those kind of interpretations can be done on MRI. So like every bone tumor, what is the extent of the tumor, whether it is going into, whether it is lesion in the cortical area, whether there is any marrow. So it will tell about whether the lesion is benign, aggressive, malignant, whether it is primarily bone or whether it is primarily soft tissue. Now, all those informations can be obtained by MRI. So what are the parts of the tooth? So can anyone tell about what are these structures from 1 to 8? What is 1? Alveolar process, alveolar crest. What is number 2? Cancellous bone is there actually. This is the bone. This is the crest. That is the bone. 3. So what is there? 3 and 4. 4 is? I never remember. So what is 3? Dental papilla is there actually. Or what is 8? Lamina. That is the root. That is the lamina. That is the canal, alveolar. So at least so these are the structures from where the things can arise. What are the contents of the pulp, what are the contents of the enamel, and subsequently these give rise to certain form of tumors and the developmental process when either the tooth is coming up. So most of the time when it is either the patients are asymptomatic of these tumors, or they are coming if there is no eruption of the tooth. So then you do an intraoral radiography, and subsequently you see that there is something lying just either encasing the tooth, below the tooth, related to the tooth, non-related to the tooth. And that's how most of the tumors are. Per primum, if they are discovered, it's by the caries. So caries is the most common that comes with the symptoms. If they are not coming with the symptoms, then it is an asymptomatic cases. The rest of the whole of the tumors are asymptomatic. Caries is the only presenting with the symptoms. So the rest are mostly asymptomatic. So at least, so that's how we will approach these lesions. So this is actually important. So what we use in the radiography examination and MR imaging. So whether the patient is having any caries of the tooth, whether there is any fracture of the tooth, periapical inflammation, whether the tooth is vital. Subsequently, whether it is solitary and multiple. If it is solitary, then all the tumors classification come. If it is multiple, then subsequently whatever it's multiple myeloma versus metastasis versus this. So all those tumors will go. Size of the tumor. So there are certain cystic tumors which are less than 2 centimeters in size. If they are more than 2 centimeters, we will see example. So the differentials of more than 2 centimeters is different. The differentials of less than 2 centimeters are different. Then whether the lesions are radiolucent, they are mixed. Okay. The location and the contact with the tooth. So if it is related to the tooth, where it is actually located, and how much it is, and which part is located, whether it is crown part, whether it is apex part, or there is no association with it. Then if there is a calcification, and we are suspecting it is a calcification, then CT is the ideal modality to look for whether there is any calcification within the lesion. And subsequently, it has to be done like that. If you want to see the margins, so again, the same rules will apply, whether it is a well-defined, whether it is an ill-defined. Okay. So like mostly cystic tumors, most of the benign tumors are very well defined, sharply marginated. Most of the malignant tumors will be having like well-defined ill margins. Then what you come, squamous cell CNA infiltrating into it, some other malignant tumor, Osteitis sarcoma. So then you have to see then whether there is association of periosteal reaction or there is no periosteal reactions. And if it is cystic, so whether it is just pure cyst or it is septations or capillary projections or it is solid. Okay. The things that is concerned is the metallic articles. In this region, most of the image will be distorted. Almost everybody is having some kind of other kind of feeling. The distortion is more in CT, less in MRI. So actually, if you want to see in a distorted this metallic filling, then MRI is a better investigation as compared to the CT. Have you seen buccal CMA sometimes? The significant artifact comes because of the dental filling. So they are more prone for artifacts, but MR it is relatively lesser. So if you want to actually image in a patient who is already having dental filling and it is difficult to give an interpretation on what you call as CT, you do a supplemental or radiograph, and if it is not giving any clue, then you can go ahead with an MRI. Okay, so these are the things. So these are the three things you have to remember. So this is the most common type of abnormality that you will find out on the oral radiography. 80% of the work of the dentist is based on this. Most common. Always write it down that this is this. Whether you know, you don't know, there should be one differential of this. So the tooth has to be non-vital. Either it is fractured, the pulp is open. So these are the things. Whether it's acute and chronic. If it is acute, then typically you will see the abscess formation. And it can either give rise to hematogenous spread, then it will be a systemic infection and all those kind of things. If it is spreading only in the mandible, if it is marrow is involved, then it is osteomyelitis, but it is involving the subperiosteal region or something like this, this can give rise to. Very good. And if it is going into rate and going into the soft tissues, then it is the abscess and cellular. It is typically like mastoid. So the features will vary, whether it is going into the soft tissue, whether it is going to the bone, whether it is going to the middle ear. So whatever the surrounding structures, so it can go. Then if it is chronic, then it is the granule malformation. In that, if you take biopsies also, sometimes it can give rise to sterile cultures. So the bacteria might have died, but now there is a granule malformation and that is slowly expanding. And if the root is, if the teeth is removed, and then you see some cystic areas in the bone, then it is a radicular cyst. So there is a caries, somebody has removed the tooth, and subsequently you see there is something lying at that region, that is the radicular teeth, radicular cyst, sorry. So, we draw this diagram now. Don't forget if it comes. So, there are many lesions. Actually, if you classify according to whether it is in contact or without contact, so periapical, pericoronal, and no contact the tooth. Subsequently, 3, then you actually redistribute onto 3. So total will be 9. So 9 subsets will be there, and then subsequently you can organize these things. So if we go by the well-defined radiolucent lesions, so what are the most common? So last time we have also discussed in the last lecture. So tumors that are common in the extremity are not common into the jaw tumors. You never ever suspect per prime that is the first differential. That should be the last differential. So most of the time it is related to the tooth and its surrounding structures. So the cysts that are common is the radicular versus residual cyst, dentigerous cyst, primordial cyst, and nasopalatine, lateral periodontal, and static bone cyst. So actually these, so the two most common are the radicular versus dentigerous. So these are the two things. These are not so common. So what is the location? It is located into the apex. What is the location of this thing? There is no contact. So tooth is not there, and because it has already been removed. What is the location of the dangerous cyst is pericoronal. So if you remember these 2 or 3 things, then actually on rest of the cyst, most of the time they don't have any contact with the tooth. So you will know that if there is a cystic radiolucent structure which is having apical involvement, then these are my differentials. Okay. So if you see this, okay. So the most important information is that the tooth is not vital. So there is something which is already fractured or already carried there or something, but it is not almost a dead tooth is there. Location. So always remember this has to be there. The history of caries should be there. The location you know by looking at the radiograph, and because the granuloma it will exert an osmotic pressure. So most of the cystic lesions they will expand like simple conces. It is always under osmotic pressure. So if the moment you puncture it, the healing will start because the pressure is released. So most of the cystic cells that are expanding, there has to be some theory behind it why it is expanding. So people are postulating that osmotic pressure, that is, so when it will grow, it will actually expand slowly. So there is a constant this thing. Have you the pottery, how they make it? So you will touch it and it will expand. Touch it will expand. So the kind of pressure that is coming constantly, it is there. So usually it is less than a centimeter in size. You will see it is uniform, well-defined, sharply marginated. Mostly they are unilocular. So whether you do intraoral radiograph or you do OPG or you do MR or whatever it is. So if it is related to the infection, then you can see the enhancement. So the enhancement will be thick and granular. So everywhere it is there, it is related to the infected tooth. There is a significant granuloma formation. Either it can enhance very homogeneously, it's full granulous tissue, and if there is an abscess kind of formation, then it is the peripheral thick film of enhancement, and sometimes you can see restricted diffusion in the central part. So these are the various manifestations of odontogenic cysts, radicular cysts. So dentigerous. So whenever we are talking about all the cystic structure, whether it is radiopaque, radiolucent, or whatever, you have to know the location of the tooth. So whether it is erupted, non-erupted, whether it's encased within the cyst, it is outside the cyst. So what is whether the crown is inside, whether the root is inside. So it is the most common developmental cyst. So that is acquired by infection. It is the developmental. So it is the most common developmental cyst, and it is around the unerupted tooth. So most of the time the patients are coming up, there is no teeth are like there. So mostly the molars and the canines, they will grow in the later part of the life. Okay. Sometimes they don't grow in some patients. So whenever they are visiting and you do a radiograph, then you will find out there's a cyst at the site where it is an unerupted tooth. So that is the most common way of presentation of these lesions. Okay. So the permanent third molars and the maxillary canines. So you will find that is the location. So you should know where it is. All these jaw tumors and all. So they have a special predilection for some sites. For this, because this is the site where the teeth will originate very late. They will come very late. So if we see it here, so what is the location? You have to search. Yeah. But then, so usually asymptomatic detected when they are failed to erupt, associated with imperative. So all the abnormalities that are associated with unapparated tooth can be associated with dentagere cyst. So whenever I will say if this is related to the failure of eruption, then you can think of association. You can find out like dentagere cyst, you can find out complex odontomas, you can find out any other abnormality that can be led by unapparated tooth. So all those can be seen in one patient as well. You can see in isolation, you can see in association. So these are the things. They can grow a little bit more. So if they grow too much, they can displace the teeth. Radicular cyst में ऐसा नहीं होता. That will not displace it. So it can grow and it can displace the surrounding tooth, and that's how you will diagnose it. So most of the time it is also very well marginated, very well circumscribed because it's a developmental in origin. You can see thin cortices that are formed up. The differentials will be Ameloblastoma and Teratogenic Odontocyst if they are unilocular. If they are multilocular, then there is not a differential. Okay. But sometimes they can be small and they can be unilocular. So at that time, there can be differentials between Ameloblastoma and Odontogenic Cyst can be missed in the early stages. But the percentage of unilocular is between 2 to 10. So only 2% of the time your differential, 2 to 10% of the time your differential can come as Ameloblastoma when they are small. But if they are big, then there is no difference because most of the time they are multilocular and there is expansion of the bone that will not happen into this thing. So we will discuss when it comes the Ameloblastoma. So that you have to remember. So there are other cystic lesions. So it is like this thing. If you see a very sclerotic rim that is surrounding this area and there is an expansion, then it is most likely to be cyst in that location. If there is no sclerotic rim and there is no dilatation, then it is more likely to be the foramen. So then there are some other structures. I am not covering the simple bone cyst and ABC and everything. The features of extremity and SL jaw tumors will be the same. ABC will be unilocular. There can be thin, subtle perceptive enhancement, but without any association with the bone. Simple the ABC, there is no association with the tooth. Sorry, there is no association with the tooth, both in the SPCs and ABCs, and can have multiple fluid levels. It can have marrow edema if they are starting growing. So these are the topics which I have not discussed. Then radiopaque lesions of the jaw. So what are the radiopaque lesions? So you just remember these things. So you don't have to remember each and everything because even if you write down two main headings in all of them, then there are 6 or 7 most common entities that will cover around the 80% of the spectrum. So just remember 2 or 3 the upper ones, not the lower ones, and go by the incidence. It should not be like that you are writing down SPC, you are writing down ABC, but you will forget to write down dentagere and radicular and all those cysts. So that are more common. There is incidence wise and the peak of wise. So the odontomas, they can be complex and they can be compound. We will discuss what do you mean by the complex and the compound. The location. So it is pericoronal. So odontomas can be associated with which kind of cyst? Dentagere cyst. So they can be because they are also the failure to eruption. So it may or may not, but most of the time it will be associated in the pericoronal location. Then cementoma, they can be mature, they can be, if they are focal, you will call it as osseous dysplasias. Then FDs don't have any contact. So whenever you are mentioning, just mention it, and below sideways you can draw the diagrams, then it will be easier. So you don't have to write down all those things of each and every this thing. If you are maintaining this kind of picture, then it is easier to be seen and easier to be remembered and easier to be written in the exam. You don't have to write the full question. So FDs, there is no contact. Then condensing osteitis and focal sclerosing osteitis, they can be in periapical and pericoronal location. Then Pagets, usually it is a bone tumor, so there is nothing. Sclerosing osteomyelitis, usually because most of the time they will start from the infection that is located in the apex. So that is how they will start it. And sometimes unerupted and impacted tooth, that can be there, and it can be misinterpreted as that there is some tumor. Okay. So it is unerupted tooth, dysmorphic, and sometimes the people can call it hematica. It looks to be tumor in that location. So most common, if it comes to be an odontogenic origin, then it is the tumor. So it is the most common odontogenic origin. Mostly it is like hematomas condition. So the chances that it will recover after removal is less. And even if you want to observe, you can observe it. So most of the age group is the pediatric. So it is less than 15 years of the age group that you see these kind of lesions, because the history is an eruption most of the time. So wherever there is a non-erupted kind of things, they are mostly located into the pediatric and adolescent group. Okay, so you can see the normal tooth-like density, and then there is a surrounding distinct radiolucent line. So usually, if you see this radiolucent line, and you see a teeth-like density structures, then it is going to be an odontoma. The only thing, if it is like this is the tooth that is there impacted, and that is the primordial dental tissues. Okay, so if it is many and it is difficult to differentiate between the tooth and this thing, it is more likely to be in what is called as complex. And a compound, it is usually well-formed tooths. They are rudimentary, but they are well-formed. In this, it is just a crumpled tissue. In this, you can see, count the numbers 1, 2, 3. If that is the case, then it is a compound. If it is more than 2, it is going to be an odontoma. If it is 1, then you don't know whether it is an unerupted tooth or it is a tumor. So that has to be there. And usually there is a lucent lining. So whenever you will see there is a lucent line that is there, actually you can see that. So there is a lucent line. So the density will be like that of the normal tooth, and there is a distinct line. Then you can classify this thing. It will be seen in the pediatric age group. It is seen in the history where there is a ferine to, and you can observe these tumors. Then bone-related lesions. So whatever you know, fibrosis lesions that can occur in the extremity, that can occur here also. So there is no location with the tooth. There is only a per primum bone tumor. Okay. So what is this? The density. So if you see this and if you see this, so it is very fibrous, opaque like this thing. So it is relatively less. So there isn't fibrous kind of association. It is more of osseous. So sometimes we cannot differentiate into further. So you can notice an Fibrous Dysplasia that is burst down. And subsequently, histopathology, there are so many markers that are there, and they can further differentiate. So if it is not growing, and that is the most common location, is the most of the time it is Fibrous Dysplasia. What is this? This is cherubism. So then you can have this Ossifying Fibroma. So it is more of fibrous because ossified component is very less. Most of them it is the soft tissue that is there, that is the fibrous component. So this is the ossifying fibroma. This is the Pagets, or it is the mats. Mats can also be osteosclerotic. How we differentiate? So there is expansion of the bone. That is diffuse without any deformity and contouring and only osteolytic areas. And if you do if you see the HU value somewhere, it should be having some fatty content. If you do an MRA, you will find the trabecular thickened and containing normal narrow spaces. So that's how you diagnose Pagets. So there are many other benign tumors that we can see in this location. Exostosis, we have discussed last time. So I will not reinforcing them. Osteomas and osteochondromas and chondromas, synovial chondromatosis, and some other giant cell tumors. So how will you differentiate exostosis? How will you differentiate osteoma? And so if you cut a tree and there is branching, so whether they go into one direction, it will always go in a dichotomy forms. So it will grow away. So the main bulk of the will be like this. So it will take a turn. It will go on that side. So usually when they start, the injury will be always at the fascial injury. But if you see most of the osteoma, they will be metaphyseal located. Because by the time that bone has grown too much, but that bone has not grown that much, because it is smaller to it. So if you see, then there is all those features are there. It can have cortex, contains the cortex, medulla with the medulla. There is a cartilage cap. So cartilage cap will be like the epiphyseal cap, which is of encountered origin. So like similarly in the physis. Subsequently, it will mature like that of the facing when there is a fusion. So they can grow till there is a no fusion. So something which is growing after the fusion, it's very simple. So that's how the hypothesis is. But you should remember exostosis. There is a contact with the cortex, medulla with the medulla. That kind of picture is there, then it is exostosis. Osteomas only arising from the cortex. Exostosis will have cortical continuity. Osteochondromas will be these things, medulla and this thing. Chondroma will have cortical central cartilage areas. There is a peripheral rim of calcification, central cartilage. Senile chondromatosis always gain joint in that location. Jaw. Giant cell tumors, we can have many these things. So ABC can have, Brown's tumor can have. So then solitary and multiple, we have to do it's multiple, then Brown's tumor we have to rule out. It can be seen sometimes in LCH, it can be sometimes seen in chondroblastoma, it can sometimes seen in case of ABCs, it is sometimes seen in case of giant cell containing lesions. There is a list of 10 that is there. So it is osteolytic, osteosclerotic, aggressive, having periosteal reactions, the differential will be different. Then mixed lesions, which sometimes can be radiolucent, sometimes can have some opacities. So what are these? So we have discussed some of these tumors like Paget and Fibrous Dysplasia and Odontomas and all those things. Some we will discuss after this. So there are some intermediate Ossifying Fibromas and Osseous dysplasias. Like half of them we have discussed earlier. So this is cystic, but this is a tumors, locally aggressive tumors. So we have till now we have discussed the benign tumors. So what is ameloblastoma? Most common tumor that we will see, at least in our hospital. Whatever the morphology is, the diagnosis is always ameloblastoma, isn't it? So the most presentation is the solid and multicystic. 90% of the case tumor are solid and multicystic. So the only confusion when it arises is when it is peripheral or it is unicystic. So that population is only 2% to 10%. Among various studies, actually, it is there. The thing that is the catching point is the buccolingual expansion. So it will expand like this. So if there's a mandible, then it will expand like this. So if that kind of expansion is there, then you have to suspect that probably it is an ameloblastoma. So 80 to 90% of that kind of expansion is seen in ameloblastoma. So it will expand this side, it will expand on that side. Okay. Location. So location where it is the posterior mandible. So 80% of the tumors are located into the posterior mandible. You don't see any periosteal reaction and this kind of picture. It is similarly like that of the GCT. And it can have benign and aggressive behavior. It can induce marrow all those kind of pictures. Either it can induce edema into the soft tissues. And typically when you do the radiograph, it is multilocular soap bubble-like appearance. So if you see that kind of expansion, so this is the fibrous ameloblastic fibroma or ameloblastic these things. When you have some osseous component in this, only purely ameloblastoma, you will have lytic areas, and then it will expand. The more the lower down, it will be major expansion. So if you see the bone that is expanding in this direction, that is expanding in this direction. So that kind of picture. So buccolingual. So when they do the clinical examination, they will see, yeah, this and this portion is dilated. So probably it is an ameloblastoma. Sometimes you can palpate the lesions. In this case, ameloblastoma, you can palpate the lesions most of the times, until unless they are very small, like radicular cyst and all those cysts, we cannot palpate. Keratocystic odontogenic tumor or odontogenic kerocyst, it is also having reduction for mandible. It is 80% of the time is seen in the mandible. It can vary from few millimeters into few centimeters, and again, the growth will be in the anterior and the posterior direction. So it will be growing from this to this direction. It will be this to this. It will be growing from along the mandible. Something like this, it's more likely to be. So because both are located in the posterior part of the mandible, you have to remember, in one there is an lateral growth, in one there is an anterior posterior growth.